Tantrums are normal. Tantrums are a normal part of child development.
Concerning behavior has more to do with skills and expectations that kids are having difficulty meeting than it does to do with motivation.
Do I really believe in this? And, do I believe that this approach is how I would parent my child? And is this culturally right for me? What do my mom and my aunt think? All this kind of stuff, like it's so hard to sort out. We were all classically taught, as I think you framed in a question to me prior to the interview, to think about antecedents. So what's going on before the behavior, then the behavior itself, and then the consequences. What do we do after? And that old model was to kind of look at maybe a child that had a reactive temperament, or was a young child that was a little bit intense and had trouble with staying calm, or a common thing like waiting, for example, for 15 minutes, or transitioning from something they really want to do to something they're maybe don't want to do, or maybe just something they just don't want to stop doing the thing that they're interested in doing. And then maybe so that's the antecedent, that's what's going on before. And then the behavior would be maybe a tantrum or refusals, or I'm not leaving, that kind of a refusal. And the consequence would be, I would hope clear communication about the need to transition, or, why we had to move on from one activity, or why you had to wait. And then classically, things like timeouts, that was sort of the old model that we would use, or, much unfortunately way before things like corporal punishment. But, most of us, and as a field, have kind of moved away from that model. It's really important to, I think, as a real basic framework when you're first learning about behavior, to think about that. It makes an easy acronym. We still talk to our residents about this ABC, antecedent behavior consequences. But for me, the key part is the antecedent. That's when you want to intervene, and to think about behavior in terms of regulation, and then skills. And what I mean by skills are things like any 2 or 3-year-old has a hard time waiting. Any 2 or 3-year-old doesn't yet know that we do have to leave the park at some point. Even if we're really having a good time and everybody else there is having fun and we've been waiting to go all day, that at some point you got to go home and make dinner and pay bills and do all the stuff that you do at night. And so in that time frame, in that antecedent, they're going to get dysregulated often. Especially if they're an intense and reactive kid, even passive kids can get somewhat dysregulated when you have to transition there. So when I now think about behaviors, we think about behavior has a function, whether it's just a protest, or whether it's an indicator of I'm really frustrated and I don't know how to calm myself down, or whether it's an indicator of this wasn't fair. Nobody told me we were going to have to leave. Nobody prepared me to transition. Nobody let me know that when we were coming, it was going to be a short period of time in a way that I could understand. So of course I'm mad now that it's time to go. So I think of it more in that context. I don't know if that was specific enough to help, but really kind of thinking through the function of behavior, why you're mad, why is he or she mad? And then can we back up and think about skills that would help us in that antecedent phase? So if we went back to that example of going to the park and preparing to transition in a minimally verbal kid with autism, it might be that we need a lot of practice. First of all, it might take us 5, 6, 7 semi-successful opportunities with brief tantrums to get to a point where we don't have a tantrum at the point that we transition. And when we get to the point where we don't have a tantrum and transition, we certainly want to go back the next day and keep practicing, being able to transition successfully. And the way we usually do that in young kids with autism is something called the pre-MAC principle, or first then activities, where first you go to the park, then we go home. First you do homework, then you get a treat or get to watch television, like that kind of an activity. And the other thing is to use things like visual supports from, say, minimally verbal kids, to show them pictures of what to expect as we transition through different settings, just so that that one, maybe waiting in the waiting room at a doctor's office isn't going to go on forever. Something's going to come after, and then after we go to the doctor's office, there's going to be a treat on the way home, or something that you want to do, so that you can set up expectations of a positive outcome, and so that your children just start to understand the sequence of events and know what to expect, because we all feel better when we know what to expect.
Some of those functions we think about, like, well, why is a student doing that? Is it just automatically reinforcing? Are they trying to get out of a task? Do they want attention in that moment? Some of those traditional functions that we've thought about. I think sometimes now we're thinking like, oh, well, maybe there's multiple reasons that this is happening. And I think what's most important is to try to really analyze. I just did a talk for a group of speech therapists last week about, well, thinking about why is that taking place? And really the importance of understanding the why is to think like, can we as providers set up the environment differently? Can we work on something in a different way? Can we get more client feedback about the intervention process? Do we know what the learner history is? Maybe you have a student who, had to sit at a table for their instruction. And so anytime you ask them to sit, they get really upset. There's just so many different variables. I think that still kind of thinking about, well, why is this taking place? Or how can I help my student immediately get their wants and needs met? Yeah, everybody's going to be so individualized, and it's going to be a lot. Oftentimes, when I was working in non-public programs for students who had very unsafe problem behavior, that was a barrier to them learning, a barrier to them being in the community, a barrier to them being around family and friends. We really tried to see like, well, why is this behavior taking place? And if we were able to help decrease that behavior and increase communication, that's usually what we were able to see, because I was working with students who were 8, 9, 18, who had no way to communicate besides using unsafe problem behavior to navigate their environment. So to be able to give somebody their voice and to help them find their voice at that advanced age is really exciting, but it also makes you feel really sad that student wasn't able to communicate until that age. And there are so many students out there that present in that same exact way.
Kids Do All If They Can is a rough summary of the fact that we now know that kids who are not doing well are struggling with the skills that are needed to be doing well. We now know that. So Kids Do All If They Can is a rough summary of that. It's also a rough summary of the fact that kids would very much prefer to be doing well. Doing well works out better than doing poorly. And both of those are my efforts to combat more traditional belief systems. For example, kids do well if they wanna. Kids do well if they wanna suggests that if a kid isn't doing well, it must be because they don't wanna do well. And that makes concerning behavior in kids out to be an issue of motivation, which it is not. But because that's how a lot of people were trained, a lot of people think that the best way to help a kid with behavioral challenges is to motivate them or to give them the incentive to do well. And I just don't see that working out very well. And we wouldn't expect it to work out very well if we already know that concerning behavior has more to do with skills and expectations that kids are having difficulty meeting than it does to do with motivation.
Thinking about, how can a child advocate for themselves? So thinking about self-advocacy, right? So if a student's talking, teaching them phrases where they could advocate for themselves, like, I don't want to do that right now. I don't feel comfortable with that. So functional communication training in that area. Or, I've had students who use AAC devices, and so we'll program some of those things into their device. I had another client who really was limited verbally. That was not their main form of communication. But so we had some of these phrases on their device. And then the family asked us in the meeting, like, can we work on verbal imitation? Because my son doesn't want anybody to be, he was actually very social, but at times he didn't want anybody to be around him. So we taught him to imitate the M sound for move. And actually that worked really quite well. So I think it's just a team-based decision. And sometimes it's good to teach those other functional phrases. There are some times, though, where, if you're a parent and a kid needs to get a shot, they have to get a shot, right, for medical safety. So there's a whole, the Essential for Living talks all about what are those essential skills that students need. And so sometimes our learners are going to have medical complications where they have to take medicine, they have to get a shot. Sometimes if you're going to the dentist or something like that, I know some students get put to sleep so they can get their teeth cleaned and some of those procedures, but it's hard and it's a fine line. It really goes back to it being super individualized because, sometimes you have to get a shot. Sometimes you have to get some of these medical things done. And so understanding that difference and trying to teach the students to, empower them with their language.
It really is delicate, and we want to make sure families feel empowered from the very beginning, that they understand neurodiversity and that they understand in a strengths-based model all that their child has to give. Like that's so critical from the beginning. But then how do you do that? How do you sort of operationalize that within the context of a healthcare system and a school system that, you have to have a diagnosis and you have to have certain deficits to be able to have the therapies that you need paid for. Of course, we're talking about a strengths-based model in a system that requires deficits to seek out services. And I think the big thing is to just help parents understand exactly what I just said, that that's the system. It doesn't mean, we're going to qualify, we'll go ahead and get the assessments done and we'll qualify, but then we're going to talk about strengths, the things that your child already does so well. And many times we see kids that do have some foundational skills around joint attention or shared affect, and some language, and they're frustrated a lot because they're working hard to communicate, but not very successful at it. And so just talking about building like that kind of skill out, because it'll help decrease some of that frustration and increase the engagement that you're looking for. And maybe make it easier to participate in activities that might be fun, for your child, to learn things quickly or more quickly. So anyways, I think that's foundational. On that piece about compliance or adherence or whatever we want to call it now, we don't use that language at all in any of our reports, certainly not compliance. And we try really hard to not use language around adherence either. That's a very provider-centric model, right? Where like I said that we're going to do this and they didn't do it. And so they were non-adherent or non-compliant. And that can be the truth true in an educational setting, or just the power dynamic of that is very provider-centric. And I don't think it's very helpful over time. It also makes people feel like they're failing. When in reality, almost everybody's doing the best they can and doing the best they can for their children, but maybe we have some knowledge deficits around why I'm recommending that we do something, or maybe I'm recommending something that isn't right. It's not going to work for your family. It's a recommendation that, I think makes sense, but I don't fully understand all the challenges that you have, whether that might be time or ability to engage, or you're taking care of your sick mother as well and two other kids. And it's just, and so I think instead of thinking around that compliance or adherence model broadly as a healthcare provider, and then in the context of behavior, in the classroom or elsewhere, he's not complying, kind of thing that you hear. I think it's a lot more helpful to move into a relational model, and a relationship-based model, where we just understand each other and know that you might be having a bad day as a child because, with a neurodevelopmental disability, because you're dysregulated or whatever, your stomach hurts and you can't tell me a million reasons why you didn't sleep well last night, like so many kids that we take care of. You have a new medicine, there's lots of reasons why you might be having a bad day. And that as a professional, whether I'm a teacher or a therapist or a physician, I'm getting paid to be here today, and my job should be to try to help you troubleshoot that and come up with some solutions and some tools to use on those days.
I wouldn't think about the skill. I wouldn't try to, number one, I wouldn't try to make a connection between here's the expectation the kid is having difficulty meeting, and therefore here's the skill the kid is struggling with. The skills are more for helping caregivers understand why the kid in general terms is having difficulty adaptively handling problems and frustrations, right? So if the kid is picking their skin, what I would do is try to word it differently. What do you want the kid to be doing? That's your expectation. That's the expectation the kid is having difficulty meeting. So that's what I would say to the parent. And yes, caregivers are often much better at talking about what the kid's doing that they don't like than in defining what they want the kid to be doing. But that's what the challenge would be. How are we going to word that so that it's an expectation the kid is having difficulty meeting rather than what the kid is doing that we don't like? And the reason for that is if we try to talk with the kid about the thing that they're doing that we don't like, they're not going to talk to us. They're going to think they're in trouble. They're going to get defensive. They're not going to talk. So how would we reword that so that it's an expectation the kid is having difficulty meeting?
We have to think a multidisciplinary approach. And for somebody that is physically abusing themselves, first of all, you've got to make sure there's not a medical sort of thing going on. Because there are some kids that have these things that look like terrible tantrums or meltdowns where they're banging their head that actually are seizures. So sometimes when parents are very confused about, like, I don't even know what to do, I certainly would video my child and then make sure a doctor looks at it. So you've got to clear out doctoral, the medical sorts of things, and then you've got to look at, do they do they have a way to communicate? Because sometimes if we're just focusing on a person verbally talking, that can add to kind of the angst of their situation. So, a good multidisciplinary team of a communication, speech and language therapist, an occupational therapist, and a BCBA, I think in combination, there are BCBAs that are fabulous when they take the full understanding of the neurological complexities of the child. Because and I've sat with families when, like an ABA said, well, that's not going to work. That's not going to work because you're not, and then they'll tell the parents they're not doing it enough or something, when really it's a complex sort of thing. So you can't just focus on one thing while you are, because what if it's a sensory need, and part of the head banging is related to hypo reactive sort of situation with craving those different kinds of feelings, and then they're frustrated and they have no way to communicate. That's where the perhaps assistive technology, perhaps it's pictures, but it's like you got to do it all at once. And there are wonderful clinics for families that do all of that. And if families can think of it as, because they think behavior, it's a behavior, so I need a behavior therapist. A behavior therapist can be very helpful, but only if they are fully knowledgeable about that child's entire kind of like history and other sorts of things.
So I want, families to understand that, and to understand that the therapy that they start with needs to work for them and be aligned with their values. Because at the heart of this resistance around ABA, I think it's just that, like, do I really believe in this? And, do I believe that this approach is how I would parent my child? And is this culturally right for me? What do my mom and my aunt think? All this kind of stuff, like, it's so hard to sort out. And that can all be handled in the context of your provider relationship and a high quality relationship, just by asking families what they think, and does this make sense to you? Are you worried about it? And, 5 years ago, I didn't say, hey, we're recommending ABA. What have you heard about it? But we certainly do now, always. And then I say, we're recommending ABA. A lot of folks have read it. Have you ever heard of it? Have you read about it? And then we talked very specifically about what I hope, just what I just said to you, what I hope ABA will look like. And then we see people back. And it's definitely true. I just described that long process to getting matched up with a company and a therapist, and the therapist comes out and you're disappointed. It's clearly not a good fit, and our nurses, social workers, and providers will then work with families. We hope they call us back when that happens, instead of just engaging from therapy. And certainly we encourage them to go back to the company they're working for first, or working with, the provider they have, and see if they can get another provider out, or if one of the supervising board certified behavior analysts can come out. If that doesn't work, or the company's asking for things that you're just not comfortable with, 30 hours a week of therapy, right away, something like that, that's too much, then we can help them find another therapist. And we do have to do that, but I will tell you that, I've done this for, almost 20 years now, and that families that stay engaged in therapy and find a match that works for them, we get to those functional outcomes I was talking about before, around communication and joint attention and interaction, and the ability, to learn naturalistically by imitation. we get to that much more successfully, for when families stay engaged. And some of the toughest challenges we see are families that get frustrated because the system's so hard to navigate, or because the care that they were offered just wasn't aligned with their values and and then they maybe withdraw, and then it's not working in school either. So then they're homeschooling, and then we'll see some of these kids that end up in the hospital at times, even with feeding difficulties, and that's a really tough place to start from. And in the end, we have to kind of end up going back through therapies, and but those are some of the most challenging and sad, frankly, patients we care for.
As a school team, I have had parents say, well, I want my kid to work on an 8-step conversation about a non-preferred topic. And I'm in my mind thinking well, that doesn't seem very neurodiversity affirming, and it doesn't seem functional, and it doesn't seem like any goal that I would set. And then you kind of get into these critical conversations because, let's say that you are a parent and you've heard bad things about ABA, and then you go to a school district and your speech therapist is also a speech therapist and a BCBA, or the teacher is a BCBA and a teacher. You say, well, I don't want my kid to have ABA. Well, ABA is all throughout your day. It's more than what we can even talk about in our time together today. But you need to feel comfortable with the interventions. The school team could say, well, based on our assessments, this is our intervention plan. And ethically, we as professionals with our scope of practice and our scope of competence are recommending these interventions. And if you don't want those interventions, you probably just have to document that somewhere. And then it becomes this professional dialogue, and conflict. I just read an article on conflict that was in the ASHA Journal for Speech Therapists. And basically it's about conflict in IEP teams. We're always going to have some level of conflict. It doesn't mean that's a bad thing, but we can work together. We don't always have to see eye to eye. And in these cases where we have an autistic learner, and we have lots of professionals who want to try to help, we all have a different level of expertise and background that we're going to bring to that. And it's just making sure that we try to be collaborative in that process. So yeah, a parent could say, I don't want you to do this. And if it's a school-based team, they'd say, okay, we just need you to document. Because if you come back in 2 years and say, you know what, I really want us to have ABA now, or I really want us to do this intervention, why didn't we do it the past 2 years? Then we have all this time that we didn't provide evidence-based, robust instruction. And so we don't want to lose that paper trail. And it's okay for parents to change their minds about things. It's a big decision and something to be, not taken too lightly.
So flopping and eloping are things that we want to get rid of. We don't want those to be ongoing behaviors. Tantrums are normal. Tantrums are a normal part of child development. Obviously, if they're happening all day, every day for hours on end, that's abnormal. But a tantrum a day, a couple of tantrums a day is not abnormal. The way that I view tantrums, which has some science behind it, is that a tantrum is a child has been holding it together all day long at school or daycare or whatever it is. And, there's a lot of stress building up in their mind and in their system, and they just got to let it out. Right. So I've seen kids where, they held it together all day with all their subjects and all their homework and what have you. And then it's, mom put the chicken on the wrong spot on the plate, and now I'm going to lose it and have a tantrum for 10 minutes. Is it that we need to have an intervention about where we put our chicken on our plate? No, it's that child just had some stress built up in their system and they needed to let it out, right? So it's normal and it's okay, as long as it's not really extreme or violent or too much or too long. And there are some guidelines about that. But if your child, if the tantrum is less than 10 minutes and it's happening, once a day or twice a day or less, I would not worry about that. The big mistake that people make is a child is having a big tantrum and the grown-ups come over and they say, tell me what's wrong. Let's solve this together. Why are you doing this? Stop that, screaming. And it's no. As you said, Karen, we got to just let it ride out, right? Because it's this big ball of emotion and energy that they need to get out, right? Once they get it out, then they can have more of a rational conversation. But in the middle of a tantrum, the front of your brain, which is where all the reasoning and logic live, is totally offline. We are thinking with the backs of our brains, our animal brains, and there's no logic, there's no reason. So it's pointless. I tell this to parents all the time. It's like if I could walk around with a sign on my head, it would be, if someone's upset, don't try and teach a lesson, right? That's not the time because that part of the brain is not working. So when a tantrum is happening, let them go. I try and check in every few minutes and say, do you need a hug? Do you need anything? Water? So they know that we're there to support them. But we're not going to try and talk them out of the tantrum because that's not going to work. And the tantrum is a normal, healthy part of development, even though it's unpleasant.
It's one of the hardest things because in the moment, a lot of times, if a child is already dysregulated, there isn't a lot that you can do, and whether it's wear a helmet or use some kind of, arm restraint, or it's just really not the solution most of the time. And there's a model called zones of regulation that I like because it has a visual representation of a green zone, just like stoplights, green, yellow, red, a green zone being you're very well regulated, just like you and I are right now. We can talk about things. I could say something, I hope, a little inappropriate, or you could too, and we give each other the benefit of the doubt, and we tend to move on and maybe even support each other. Or if, somebody said something where they were a little frustrated, you might be able to help bring them back. So that's a green zone. Yellow is when you're a bit dysregulated, but you're not yelling, screaming, in self-injury, tantruming yet. But you're closer in yellow zone. I always tell people, think of like driving in a traffic jam in the Bay Area, about to go over the bridge in a rainstorm. And then that's when somebody chooses to give you advice about driving. Like it doesn't take much to kind of get you mad, in that kind of a situation because you're maxed out already. And so many kids we see, and the kind of dynamic that we try to work through with parents is to recognize yellow zone behaviors and then to act when they're in that zone and to help kids find an off ramp. Meaning if it's just 5 minutes of a break, or everybody's quiet for 5 minutes, or we step outside for 5 minutes, initially almost always that coping has to come from parents, caregivers, teachers, therapists that can recognize when a child's starting to get dysregulated. But within that model, if when I see a child starting to be dysregulated, or any therapist, parent, or teacher does, and you start to give a child that language, are you starting to get frustrated? You look so angry, buddy. You're getting mad. Let's take a break. Are you ready for a break? I'm going to stop talking. And I see parents do it all the time intuitively that are good at it because they know like can't be, loud laughter in the room will upset a child, for example, and we'll laugh loudly and then we'll take it way down for a couple of minutes, and wait, and that's where I think we're most effective. If I'm being honest, I know that when you're driving and your child's throwing things from the back seat at you and hitting themselves, that you want a solution right then. But the solution really is to pull over and get to safety and to think through what the triggers were, and to be as intentional as possible, about either avoiding them or building some skills so that frustration tolerance, so that ride that you need to take every day can be a little more well tolerated. And that just takes time, and it's part of why when we see families that are in real crisis, sometimes we really have to chip away. It might be, 6 months, 12 months later when we see a real significant change. And we certainly prescribe medicines. We know that there is a group of medications called neuroleptics that can be helpful in children that have self-injurious behavior, property destruction, or aggression defined as, hitting, kicking, punching, biting, scratching, real physical aggression. And we certainly will use those at times to get through a period of time as we build skills, because it can help with regulation, and maybe think of it as expanding out your yellow and green a little, and maybe, making it a little harder to get to the red zone. But we want to stop, those medicines when we can too, because they have a number of side effects.
When something happens, people are like, somebody walks by a kid in a classroom and does like that to him, and so then people think, well, it's very clearly this kid's fault because he, elbowed that person, and I always, well, why do you suppose that happened? In extreme cases, then when you do a functional behavioral assessment, I fault how many schools and systems do FBAs, and that I look at it when I do FBAs as like a 24/7 sort of document where I will follow the kid throughout the school day, from when they get on the bus or off the bus to when they get back on the bus. I work with families, and observe the child there, and then I work with the teachers, so, all of it. And some of the things I ask are based on like the at the federal level, the PBIS kind of model that they've got for functional behavioral assessments, but getting to the why is critical. Now, in the case where somebody elbowed somebody, it was that they both lived in the same project, in the housing project, and there had been a feud and problem going on for like 2 days. And the last thing that the person that got hit did was something very mean to the student. And so you can't just like, it's like the iceberg, you look and you see the top of the iceberg, but then all the things that are leading up to what's under that iceberg. Is the child sick, or were there issues and problems previously? One thing I always say is there's always a reason for the behavior, and just because you don't know it doesn't mean there's not a reason for it. And people always think, no, absolutely, I saw it in my own eyes, there's no reason, that kid was just being not bad or something. And so I really feel like the first thing that parents need to ask when approached by the school or about an incident is to say, well, why do you think that happened? Tell me about why you think that happened. And then I also like to help parents say, make sure that they're telling you completely behavioral terms of exactly what the student was doing, not judgments or opinions, but if they say your child is out of control today, and it's to say, well, okay, why do you think that is, and then what exactly were they doing? Can you give me an example of what they were doing? Well, I'm not sure. I'm not sure. They just had an attitude. And it's like, well, what were they doing? I mean, it's like you got to press to find the exact, because you can't get at the why if you don't kind of even know what the person was doing.
I think compliance and our obsession with it is at the root of a lot of big issues that are not going well. I don't think that the goals of an IEP should be translated as behavior most of the time. I think unsolved problems should be the goals of the IEP. That's what we're working on.
I think like compliance or on-task behavior, they're very abstract concepts. And what they really are is, we're rewarding for not doing something negative. And that kind of flies in the face of operant conditioning. So again, we want to reward the good stuff, don't reward the not so good stuff. So the way that I view it is you're going to get much more out of a kid if you say, these are the very specific things that I want you to do. For short chunks of the day, I want you to morning, come hang your coat, put your book bag away, put your lunch away, and maybe, complete your worksheet, whatever it is. And we want to see if those things, accomplishing those things rather, can help a child feel good about themselves, feel like they're getting good feedback. And generally speaking, when we do that, we start to build what's called differential reinforcement. So we start to teach the child that, oh, if I do good stuff in the classroom, my teacher notices it. They praise, they reward, and I feel good. And when I don't do those good things, I don't get that good stuff, right? So then over time, especially if we have a good program and we have everything kind of in place, now they learn, okay, do good stuff, get good feedback. Don't do good stuff, I don't get good feedback. And over time, there's more of the good stuff and less of the negative behaviors. That tends to work better, in my opinion, than these abstract kind of like, you were on task or what have you. Not to say those types of things never work at all, but I think having more concrete goals tends to work better. And then especially for people with disabilities for whom abstract reasoning is hard, it's better to have things be really concrete, like you did it or you didn't, right? What is an on-task behavior? It's a hard thing to define.
Concerning behavior is communicating that there's an expectation a kid is having difficulty meeting. And we do need to find out what's making it hard for a kid to meet the expectation that's causing that behavior. But not by asking the kid why they're exhibiting the behavior. We know why they're exhibiting the behavior. They're frustrated about an expectation they're having difficulty meeting. So we don't need that. We don't need to ask them a very common question that caregivers ask kids, why'd you do that? And the answer is always, I don't know, right? That's not what you're asking in this model. What's making it hard for you to complete the double-digit division problems on the worksheet in math for homework? Now you're going to get info. And remember, it's that expectation that the kid's having difficulty meeting that might be causing them to throw a book across the room, tip over the table, start screaming and crying, all frustration responses. We're not asking them about their frustration responses. That is how they are communicating. But what they're communicating about is what we're asking them about. Difficulty completing the double-digit division problems on the worksheet in math.